So, ladies and gentlemen, thank you for coming to this medical education seminar. I'm Masato Eto, and I will chair of this seminar. So, I would like to start today's presentation. Today's presenter is Dr. Park. Actually, he's associate professor, Department of Medical Education, College of Medicine, University of Illinois at Chicago. So he's also a visiting associate professor of our department. So today's title is Curriculum Trend in U.S. Undergraduate Medical Education. So Dr. Park, please start your presentation.
Okay, good evening. Thank you very much for coming. This is now the fourth talk out of the series of different talks that I'm giving. And so tonight's talk is about curricular trends, and particularly focusing on American medical education. And if you recall, the first talk was about assessments related to clinical reasoning. The second talk was about mastery learning, and then the third was about translational research. So this is now the fourth. Sort of, I kind of think of this like as a series, helps me kind of prepare for this lecture. And so for this one, the reason why this is a little bit different from the prior talks is that this is more at a micro level of what's going on. The prior talks were sort of more overarching, larger ideas, how do you do mastery-based learning, or how would you do outcomes-based research. This is more looking at specific, what are some examples of things that are being done in medical school in the first 2 years of medical school, at the fourth year of medical school. What's happening in residency? How are people feeling? And so the title also includes examples. So there will be examples after examples here. And so I'll start by giving a brief overview of some of the curricular changes in medical education. And then I'll follow up with 3 examples. So the first example has to do with teaching of physical examination in preclinical medical education. So this is the first year and second year of medical school before they get into the clinical training. And because in the medical education literature, there's been a lot of discussion of physical examination, and a lot of letters to the editor, blah, 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 letters to the editor, replying to the former letter, and then response to that letter, and then another response to that letter. So in academic medicine, there's been a lot of back and forth discussion that's been going on about how do we teach physical examination skills. So I'm not a physician, but seeing all of these different discussions in the literature really raised my interest. And so I'll talk about why I was involved in this particular example. And then the second one has to do with graduating medical students. So this is fourth year of medical school, just before they go into residency. And the reason why this has also become quite appealing and of interest to a lot of people was because a few years ago, residency program directors started saying the students who are coming into the residency programs are not prepared enough, so you need to do a better job. And then the fourth year program directors or medical schools were saying, well, you need to just basically teach them we're doing our job. And so there's been a lot of back and forth, who is supposed to train them, and what is happening during this transition from fourth year of medical school. Again, in the US, medical school is 4 years, and then when they go into residency. So that's the second example. And then the third example is an example from residency, looking specifically at general surgery. So I selected one specialty, and there's been also a lot of discussion about the curricular structure of surgery residency program. So again, 3 examples, one after the other, just kind of giving you an awareness of different discussions. I mean, so you can kind of think of this as, if you were to go to a medical education conference in the US, what are some of the lunchtime discussions that people are having? And sort of I picked these 3 different examples as sort of the popular lunchtime discussions during conferences. And so this could give you a sense of, these are curricular trends that are happening. And then I'll conclude with some implications and further thoughts. Okay. So I'll start with a recap from my second talk, which was called the T-steeping model. And if you might recall, this is an idea that was published in Brian Hodges' academic medicine paper and also in Linda Snell's medical teacher. This came about around in the 2010 period, but maybe a little bit before that. The idea here is that you have a tea bag, and you put your tea bag in hot water, and you let it steep for a few minutes, for a fixed amount of time, for a few minutes, and then of course, afterwards you have good tasting tea. So the variability of the good tasting tea really comes from the type of tea bag you buy. So if you buy very expensive, high quality tea, then automatically, because water is all the same, you get good tea. So this was the idea that these 2 medical educators have been saying with respect to medical education, and the reason why we need to sort of move away from this fixed time of medical education. So the idea is, you have medical students, you put them in hot water, the water is like medical school. And of course, if you're in the US, it's 4 years. If you're not in the US, it could be up to 6 years. And then you have competent physicians. So this was the example that they were saying. You kind of put them in hot water and you pick them out. And so as long as you select very good, smart students, no matter what we do, at the end we're going to have competent physicians. So this was what they're saying, like a call to change what's happening in medical education. That this was just one of the many different examples that people have mentioned. And the reason why this has become sort of an interesting idea, I mean, so the idea for me, because I'm not trained as a physician. I've only joined medical education in the last 7 years or so. And so for me, when I came into medical education, there were so many things that were happening. Like one year, there's all these new mandates by the accreditation agency. The next year, there's something else happening. And then when I talk to my colleagues, why are there so many changes that are happening? Was this the same case 20 years ago, 30 years ago? And they said, maybe not so much, but a lot of activity has happened since about mid-2000. And so I think a lot of it had to do with the Flexner report, because this was published in 1910, and we're now reaching this point of 100 years after the Flexner report, and so people have been really questioning, is the medical education system happening correctly? Are we in the right path? Should we continue with the Flexner report? So for those of you who are not familiar with the Flexner report, the current medical education structure, you have basic sciences, followed by the clinical sciences, and then you have residency. This kind of structure was identified in the Flexner report, and that was when the current medical education curricular structure was really defined. And so 100 years after the Flexner report, I think this was published maybe a few years before 2010, there were papers after papers that people started publishing, are we in the right track? And the American reactions, this is in 2010 and this is in 2014. This is actually published by the Institute of Medicine, and so this had a lot of authority in what they were publishing. And then there were the Canadian reactions as well around the same time. So what am I trying to say? So all I'm trying to say is the current medical education structure that has happened for the past 100 years, people are beginning to question this practice of fixed time, this idea of a peacekeeping model. And people are trying to think, how can we improve the structure of medical education? And so that's why there's been a lot of mandates, a lot of new regulations, a lot of new curricular structures that are being proposed. On one hand, it's very exciting because there's a lot of research. For a researcher like me, there's a lot of research opportunities to see which is better or not. But at the same time, this has also caused a lot of discussions. So I'm saying all of this to motivate today's presentation, which is about curricular trends. Where are we now in 2017? Because this is in 2010, 2014, we're now about 7 years after, and at this point currently, there's been a lot of different practices that people are doing. Okay. So, as you may all know, this is the typical structure in the US, and also in Canadian medical schools, where you have, it's a 4-year curriculum. The first 2 years are basic science or preclinical, and then 3rd and 4th year are clinical, where students would go out to the clinical rotations. After that, they would go into residency program. For example, if you're in general internal medicine, it's a 3-year program, it's fixed. You begin, and then after 3 years, you become an internist. If you're in general surgery, it's 5 years, for example. So the question that a lot of these prior articles have questioned is, are people prepared for this transition from medical school to residency? And at the same time, people are now also saying, are they prepared between here to here, in addition to from here to here? So that's sort of where we are. And as I said earlier, today's presentation is about 3 different examples. So the first example is about teaching physical examination to preclinical medical students. And this is during the first 2 years. So I'll talk more about the different discussions that are happening during these 2 years. And then the second example is about graduating medical students that happen at the 4th year of medical school. Okay. This is as you know, this is a very important time for medical students, because once they graduate, then they start residency. And so in some sense, at least in the US, the 4th year medical school is what we call sort of the unstructured, unknown part of medical school, because 1st year, 2nd year, 3rd year is very clear. I mean, everything in the curriculum is geared towards preparing the student for the USMLE, either it's step 1, step 2 CS, step 2 CK, and they're continuously getting prepared for it. 4th year of medical school, by the time they're a few months in, most students would have been done with all of the step 2 CS and CK and everything else. And they're kind of waiting for where they're going to be placed for being residents. And so there's been a lot of variability in what schools do. Some schools put a lot more structure, others are have less structure. So sometimes they tell students to do research, sometimes they tell students to go on to do electives. There's a lot of variability. But because now the residency program directors are sort of complaining that the residents that you're sending me are not prepared, what are you doing during this time? So this is the second example, because a lot of now discussions are happening, maybe we should restructure this 4th year of medical school, because they're not going into medical school, they're not going into residency prepared. And then this is my third example, which is focusing on general surgery. I'll say later why I selected general surgery. But this is now also another sort of discussion that occurs a lot if you go to general surgery medical education meetings. They're talking about, right now it's a 5-year program. Should we make it into a 6-year program? Or should we make it into a 3+2-year program? Or a 4+1-year program? So these are the lunchtime discussions that the surgery program directors in the US are having. Okay. All right, so the first example, this is based on a national survey that we administered to all medical schools in the US. This is part of the group called Directors of Clinical Skills Courses, the DOCS group. I don't know if you're familiar, they have their own conference in November each year. This is a group of, if you teach clinical skills in medical school, this might be a good conference for you to attend or visit. And their conference is usually a day or two before the AAMC meeting in the US. And so the first example is basically from this national survey that we conducted. The second example, which is looking at the fourth year of medical school, this will be based on the literature review that one of my students did, and this is a paper that's currently on review, looking at the published literature on what's actually happening in the fourth year of medical school. I mean, we see a rapid change of things that are happening. And then the third example is based again on a national survey that we did with the American College of Surgeons in affiliation with other surgery governing bodies. So these are the three examples, and I'll begin with the first example. Okay, so this is the first example. All right, so this is a few slides talking about physical examination. Again, I'm not a physician, but we know from the published literature that physical examination is a critical tool. And so physical examination, so if you're not a physician, this is when the physician meets with the patient and they do an examination. And if the skills for physical examination is low, then there's a lot of published literature showing that the quality of care is low. Medical errors also tend to, you have more medical errors, basically, if you have low physical examination skills. But what's also known in the literature is that teaching physical examination or assessing physical examination is very labor intensive. It's labor intensive because it requires humans. And so you need patients, first of all, to teach physical examination. And either the patients are standardized patients or simulated patients, or you have real patients. So you have to somehow acquire the patients. And then you need teachers, and teachers can be faculty members or senior students, residents, and so forth, who are further along in their training. And there was a sort of a survey a few years ago that were done with clerkship directors, and basically they said that 48% of the clerkship directors thought that the students were less prepared in doing physical examination. So this was a big wake-up call for a lot of the medical educators. So just to summarize, if you have inadequate physical examination skills, then the physician becomes, lacks the expertise, lacks the confidence, and then they end up doing more unnecessary diagnostic testing. What we found, at least in our school, is that if the student didn't do a proper physical examination, they would end up ordering MRIs, they would order all these expensive tests that are unnecessary because they didn't do a proper job. They also found in several literature reviews that if the student does not have proper physical examination trainings, then later on when they become physicians, the value of physical examination is not translated to their future students. So it's sort of like a vicious cycle that kind of continues. So the point is, we know little about how physical examination skills are taught in medical school. There's a lot of theories of, this should be done, that should be done. But up to this point, up to very recently, at least in the United States, we were not sure of how physical examination skills were taught in medical schools. So I'm sure if you teach, if you're clinical faculty here, you know the different types of physical examination teaching techniques. I just wrote these here because these are the ones that I am familiar with. The first is the head to toe, which is the traditional approach where they do everything from really the head to toe of the physical examination. And then there's the core approach, there's a core plus clusters approach, there's a hypothesis-driven approach, and so forth. These are different techniques or different pedagogical approaches to teaching and assessing physical examinations. So knowing that all of these different things exist, and we know that some of them are better than the others, the question that at least in the US setting that we had, was how much time is spent on some of these different techniques, who do the students practice with, and how large are the groups, because generally, small group settings are better. What are the resources? You know that it's very resource intensive. Faculty are expensive, time is scarce. Do they get compensated? If they do get compensated, what kind of compensation do they get? So these are just general questions that we had, and others. So just to put some context, the next few slides are just some contexts for this physical examination curriculum. So about 10 years ago, my colleague Rachel, she published this paper about assessing the head-to-toe physical examination skills of medical students. And basically, this is taught during the first or second year of medical school, and this is a full examination. So I don't know if you've seen the checklist, but at least the checklist that we use at the University of Illinois has about 138 checklist items. I know that other schools in Chicago have 140 plus checklist items, so it's very long. And in some sense, when I looked at it, I felt maybe I could memorize them, and I could do it myself. but I'm not sure, maybe the clinicians might. So it's a long list, and as long as you do everything in the list, you get a good score. The problem is this is very long, and in terms of the time, it takes 2 hours for a student to get through the whole exam. But what Rachel found is that this is a reliable assessment, but at the same time, it's very lengthy, expensive. It lacks context because in some sense, the student doesn't have to have any clinical reasoning. They could go in, like me, a non-physician, just go in without thinking and just do it. Just do the 140 things that I have to do. So it can be memorized in some sense. So there is all of these negative things in addition to the positive aspects as well. So this is the traditional approach, and I'm not sure how physical examination is taught, but some schools in the US still do this. In fact, many medical schools still do this. So what are some of the approaches beyond the head-to-toe approach? There's what's called the core approach. The core approach, this is a paper that came out in 2014. And the core approach is a subset of the 140. So what this guy did was he assembled a group of physicians, asked them to look at the 140 checklist items, select what you think are the core of these 140, and that's what's published here. So rather than doing everything, he identified the core, and he was saying that it's better to teach the core. And then in addition to the core, there's the cluster. So depending on the symptom of the patient, there's specific clusters of physical examination that can be done. And so the student needs to know the core, and then depending on the symptom, the specific cluster of maneuvers, examination. So that's in this paper that was published in 2014. Now you can see the dates. 2010, around then was when a lot of this discussion was happening. This was 2014. And then immediately after, I think around the same time, this was another sort of follow-up paper that sort of followed up on this core approach. This is my colleague Toshi, who's at Northwestern, and she said that doing a head-to-toe plus this core plus cluster would be a good teaching approach. So what she was saying was that do this plus the head-to-toe approach. And then, of course, there are two studies that predate this. So this happened, I think, in 2010 or 2009. 2009. This has some Japanese researchers, Otaki sensei and Nishigori sensei, and then this also has Nishigori sensei and many Japanese researchers as well. And so this is the hypothesis-driven approach. So rather than meeting the patient and doing this sort of rote memorization, it requires the student to have a hypothesis and then use that hypothesis to go about doing the physical exam. So there were I mean, these are just some examples, and there are many, many different approaches that came around and were published around the same time. So when this was published first, this came out second, and then this came out third, and then this came out fourth. So when these came out, Rachel wrote a letter to the editor about, this core approach. And then the core people wrote a reply to Rachel Yudkowsky's letter. And then there was another follow response, and then there was another response. So there was all these responses to editors' letters that appeared in the journals. So this was again in late 2014. I think the other papers came out in the summer or in the spring, and then this was sort of in the December issues that this came out. So you can see that there's a lot of now communication that happened, and the American Medical Education Conference is in November. So when we were at the November meeting, this was the hot lunchtime discussion of what should we do with respect to physical examination. And right around that time, in 2014, in addition to all of this, what was happening was the AAMC, this is the body that's in charge of the medical school education, published what's called the Entrustable Professional Activity. And so this is a set of 13 activities that medical students must be able to do before they graduate from medical school. And this came out in August, I think August or July of 2014. And their number one on their list was to gather history and perform a physical examination. So this even brought the excitement even further because all of these were happening at the same time. So I'm just trying to describe the context during that latter part of 2014. And you can see that these are developing behaviors here. This is the low behavior. This is more advanced behavior with respect to physical examination. And here you can see relies on head-to-toe examination. This is sort of at the lower end of what's needed, and then slightly higher is targets the exam to areas necessary for the encounter. So this requires more of some kind of thinking, and then performs an accurate exam in logical and fluid sequence. So this might be more of the hypothesis-driven approach and so forth. And so all of these, again, were happening in 2014. So finally, what we all decided to do was to do a national survey, because there was all of these discussion, and what we found out was that we didn't really know actually what was happening in each of the different medical schools. We know that all of these different approaches were published, we talk about them, and people were doing research at their own schools, but what's happening at the different schools, we weren't sure. And this actually came out just recently, a little over 2 months ago. So this is quite recent in terms of when this came out. And my involvement in all of these, they're all physicians, I was just analyzing the data. So that's how I became interested in this topic as well. So again, the group is called the Directors of Clinical Skills Courses, and they did a national survey of 106 medical schools. There's about 140 medical schools in the US, and so this is about more than 75% response rate. And they were looking at resources and educational practices with respect to teaching the physical examination to preclinical medical students. So in the next few slides, I will be just talking about some of the results from this survey that kind of informed us of the practices. So you can see that the dates were 2015 to 2016. And so right after late 2014, they started making the survey, and during the summer they piloted it, and then they administered it. So this was really happening sequentially. So one of the things that we were curious is how long are these physical examination curriculum? And for the most part, they were slightly over a year, up to a year and 6 months, so 18 months, most programs. And some programs even extended it up to 2 years. So 22 months is basically 2 academic years. And most of them are introduced within the first 2 months of the curriculum. So after the students start medical school, usually they start in September. So by October, late October, is when they will start this curriculum. And what's interesting is that some of them do incorporate interprofessional education. So nurses and other hospital staff are incorporated into the teaching. And in fact, the students, some of the dental students, the physical assistant students, the nurses, were in 8% of the schools taught this physical examination skills together. And most of them, the curriculum, was about 82 hours, so about 10 full working days of teaching time. Some schools far fewer, other schools a lot more. And most of the teaching happened in small groups, so 32% was in small group. About 30% of the teaching happened in the simulation center, 22% happened in the hospital or the clinical setting, and then very few were actually in large classroom lectures. So if we look at time spent to practice, most of the students practiced with standardized or simulated patients, so about 38% was with them. They actually also practiced with their peers, so peer-to-peer student practice. With real patients, it was about 25%, so a bit less, and then with mannequins and other simulators was far less, about 6%. And I think when we look more about with the real patients, this was actually a bit skewed because about 50% of the schools used less than 15%. So this is the average, but if we look at just the other end, it's less than 15%. So generally, most of the students practice with the simulated or standardized patients. And what was interesting was that the instructors were mostly generalist faculty, but there were also senior students without faculty supervision who were teaching in about 5% of the schools. Standardized patients were also teaching without faculty in about 12% of the schools. And the group size for classroom, it was about 8, and then in the clinical setting, there's between 2 to 3 students per group in the clinical setting. Probably these are with the real patients here. So in terms of faculty direct observations, most of the faculty spent time observing student-patient encounters with standardized patients, with peers, with real patients, and so forth. But only 19% observed them in all of these different categories. Here, if we look at the sequence of teaching, some schools taught them first basic skills, and then advanced skills, and then other schools taught them by organ system. And these are just some details that we were interested in looking. So again, going back to the head-to-toe and the core clusters and hypothesis-driven approach, we were surprised to find that 77% of medical schools still use this full head-to-toe approach. That's like more than 2/3, more than 3/4 actually. And then for the clinical reasoning approach, just under 60% were using clinical reasoning approach. Some schools were using both, so they would train them in this first and then move on to this as well. But you can still see this is still the head-to-toe, the comprehensive approach is still the dominant approach. And in terms of time spent teaching, the comprehensive approach, the head-to-toe approach, was about 2/3, and then 1/3 of the time was spent teaching the clinical reasoning approach, the hypothesis-driven approach. I'm not sure how it's done here in Japan or in other countries. Okay. For the assessment component, most of it was developed by the course faculty, him or herself. Only rarely, about a quarter of the time, were they using published lists that were available. Actually, there's a lot of accepted lists in the MEDED portal website that people can use. Okay, so with respect to scoring, most of them were scored live, and then generally these are all videotaped, and so for summative cases, about 40% were rescored in the video phase afterwards, and about slightly over 20% were not scored at all in the video, and probably most of them were done here. So if they were not scored live, probably they were videotaped and then scored afterwards. Who served as the patient? So this was quite interesting because if we look at the standardized patient, for summative exams, 92% the standardized patient served as the patient. And for formative cases also, and if we look at real patients, they're used about a quarter of the time for formative, but for summative, very few. And then for students, not as much as well. But real patients were not used as much. And I think when I remember, when I was in India, I was teaching in India, I think for their clinical exams, I think their clinical exams require them to do the summative exams on real patients. So you can see that there could be a lot of variability from patient to patient, but I think depending on the context, this is really different. The American case, I would say, for the most part, this is done with a standardized patient. And this was also surprising to me, who scores the checklist, because I would have thought that most of the scoring was done by the standardized patient, as is done in my school. One of the things about our school is that we try to minimize the workload for the faculty as much as they can, at least because the faculty are the decision makers. So they invest a lot of time and resources to train the standardized patients. I mean, we spend a lot of time, a lot of money doing that, and they're actually really good when we do studies. The standardized patient, their inter-rater agreement is like 95% and above. They're really good. But what we found here was that for summative assessments, it's only about 16%. And for most schools, the faculty do most of the scoring. So it's a lot of work on their part. And students do some scoring here. In my prior talk, I talked about standard setting, and again, also I was surprised because I thought everybody would be doing standard setting. Everybody would be doing Angoff or Hofstee, but only 10%. So this is the method to set cut scores. And norm reference would be like mean minus some kind of standard deviation. About a third of the schools did this. Borderline group method is another standard setting approach, far fewer did. But most schools, they had this approach where it's kind of arbitrary. So if I was the course director, 70% is the cut score. That's the way it is. That's how it was for most schools. And then if it was determined by the committee, looking at various factors, that's another third. So I think there's a lot of variability in what's happening in American medical schools. Also with respect to number of assessments as well. Okay, so compensation. So here, this is, we asked the question, I mean, how are you compensated for teaching physical examination? And these are all clinical faculty doing clinical work, doing research, and doing other things. So they're busy faculty, and they're also teaching this physical examination skill. So 20% of them were compensated with money only. 26% were given protected time only, and then 11% were given both money and time. So these were the lucky people, I think. And then about 34% didn't get anything, so they just had to do it and were required to do it. And we looked at this more specifically with, if you're a course director, so if you're a course director of the physical examination program, and generally this is sort of like a large leadership title and you have a lot of responsibilities. This is a large group, maybe like a lecturer in a large group setting. This is a small group facilitator, and this is a clinical teacher in the hospital clinical setting. So if you look at this, the course directors who have an actual title and have leadership responsibilities, they're compensated with money, they're compensated with time, even both, and only far few of them are doing this voluntarily. If you're a course lecturer, not so much money, but some of them do get some time and so forth. But if you do small group facilitating, then you get the money and sort of relative to this other group, and time and both as well. I think the people who are getting the least here is the clinical teachers who are in the hospital settings and in the clinical settings, who are only 10% of them compensated with money or time and so forth. And so the clinical educators have to do more work, as I would guess, in this context. Okay, so that is the first example. I'll move on to the second example, and then the third example. So the second example has to do with graduating medical students, and we're looking at, again, the fourth year of medical school. As I mentioned earlier, one of the things that we know about the fourth year is that it's sort of an unstructured time, and we let students do a lot of different things. So sometimes, I would have medical students come to me asking me, they're interested in learning about biostatistics because they want to do research in biostatistics or statistics, and that's okay because they're in the fourth year. It's sort of that kind of a time, and they could do other things as well. They could focus more on, if they want to be a researcher in oncology, they might visit a professor who does that kind of work. But recently, with all of these pressure coming from the residency side, it's a accrediting body from the residency side. There's been a lot more scrutiny with what happens in the fourth year of the curriculum. For example, the ACGME, which is the accrediting body, they've given a lot of mandates. And then the AAMC, which is in charge of the medical schools, are also saying you have to do this and that before they graduate. And so you can kind of see that the fourth year curriculum has become the interest and focus of a lot of people nowadays, particularly with respect to competency-based medical education. People are not sure what's happening here because, at least in the medical school side, we think they're doing very well. But then once they go into the residency program directors are telling the medical schools that they're not prepared. In fact, I was attending one of these conferences, and this was another general surgery conference, and the surgeons were saying, because when students go into residency, the dean writes a recommendation letter for each student. This student, we certified the student, completed everything. The ideas that the residency were having was that once they complete, the first 6 months or up to 1 year of their program, the residency programs will now report back to the medical school, actually, what you told me was a complete lie, for example. Or, yeah, what you told me, we confirmed because the student is doing great. So those are the kind of ideas that the residency programs are now floating because there's been a big gap between what's happening here and what's happening here. Nothing has happened to this extent, but these are the discussions that are happening at conferences if you attend this conference, which is different from this conference. So in the senior year internship, there's what we call preparatory courses that have now become increasingly popular. These are new electives, or if you're in surgery, there are surgical boot camps that students go to before they go into surgery. And some of these boot camps are very intense. That the aim is to ease the transition to residency. And so what I'll present here is a study that one of my students did, who's faculty at Tufts University. He did a literature review of all the published literature between 2006 until 2017, looking at different trends in the fourth year curriculum. What's published in the fourth year curriculum? How has it changed over time? He first found 6,000 articles and then 4,000 articles, and then came down to 817 articles during this 10-year period. So because this is during the fourth year of medical school, most of the articles were based on clinical skills. And some of them were on internship preparatory, others were on career decision making, others were on interprofessional education as well. But what was interesting was that during the past 10 years, there was a 100% increase in articles relating to simulation. I mean, there was about 52, and these are articles specifically looking at fourth year. So the article has to say fourth year curriculum. This is in the United States only. If it's outside the United States, it was excluded from the study. And it had to be peer reviewed, with all the rigor. So there was a 100% increase in simulation-based papers, and then papers that looked at competency-based framework, again on the fourth year, just looking at fourth year only. So if it had second, third, and fourth year, it was also excluded. So this is only looking at fourth year. There was about more than a 200% increase in these articles. And then for preparatory courses like boot camp, internship readiness curriculum, things like that, there was again a large increase. So here, the darker line here, this shows the articles related to the fourth year of curriculum. In 2006, it was about 43, and then there was a big dip, and then you can see that there's some increase that happens here. And this is articles that have to do with the competency-based framework as well. There's a big leap here. And you can see that a lot of the growth that happened here happened around this time, the 2010, around the Flexner report time, and when there was more and more increased scrutiny by ACGME, AAMC, LCME, and all of these governing bodies. This is the number of articles for preparatory courses. Again, there's a sharp increase that happened here as well. So again, I mean, these are articles basically showing that people are looking at the fourth year of the curriculum, and they are wanting to really change it and really try to ease the transition between medical school to residency. Also, one of the things that we did was we looked at these different studies by specialty, and we saw that the specialty that had the most of these publications came from surgery. I don't know if there are any surgeons here, and so surgeons actually have done a lot of. Surgeons actually have their own medical education conference in April each year for surgical education, and this transition from medical school to residency has been a lot of debate within the surgical education community. So I'll move on to my third and final example, which is about the general surgery curriculum. And so here, for the general surgeons, what they were concerned was that the residents who were coming into their program, they thought were not prepared. And at the same time, the residents who were graduating from their program, they thought were not prepared for unsupervised practice to be surgeons as well. So, so what they did was they ended up doing a national survey. This is also published in 2017 in July, so this is also quite recent as well. This was done by the American College of Surgeons with the Association of Program Directors in Surgery, with the Accrediting Council for Graduate Medical Education, the American Board of Surgery. So again, my involvement here was that I was only analyzing this data, and all of this was happening one after the other. I mean, the docs group who were doing the physical examination survey, they came to me and asked me to analyze the data, and then a few months later, this group came to me, and so to me as a data analyst, I mean, this was a lot of surveys were happening during this time because people were trying to figure out what's happening with the curricular trend in America. So again, this was administered from March to August in 2016. You can see that this was immediately after the docs group did their survey also. And they looked at a whole set of areas that they were interested to know. In the US, there are about 240 general surgery programs. So this was, slightly over 50% response rate. The survey is extremely long. I mean, it's like 120 pages or something like that. So I was even surprised that they responded to it. But I think they really twisted, people's elbows and arms to get them responded So this is a very long survey that they did, and here are the results. So we asked them, comparison of today's residents to 10 years ago, and this is general surgery residents. What do you think that they're less prepared for the entering residents? Here, you might not be able to see if you're in the back. This is medical knowledge. This is clinical skills, technical skills, critical thinking, decision making, and professionalism. So you can see that the top three are clinical skills, technical skills, and decision making. They thought the students were not prepared when they come into residency, that they didn't have the proper clinical skills or the technical skills. And then this is graduating residents compared to 10 years ago. So again, technical skills was very high, decision making was very high. Professionalism is quite low. I mean, everybody talks about professionalism these days, that I think they really hammered down on the professionalism part. But it's really the technical skills and the decision making that they really mentioned in this survey that was still a big problem. And we asked them, why did you think this was a problem? And they thought, they weren't giving enough autonomy to the residents because of liability concerns. Patients who don't want to be cared by residents actually was quite high as well. So that the patients didn't want to be cared by residents. I mean, they have to be cared by residents to increase their autonomy, to increase their skills. And then there were more regulations because the accrediting body were saying, we have to do this and that, and they're increasing numbers of regulations. And what was surprising was that 62%, the survey were administered to program directors. So each residency program has a single program director whose name is associated with the accrediting agency, and we made sure that that person was the one responding to the survey. So this is a busy person, but this program director, 62% of them said they need to have a significant overhaul of the 4th year of medical school. So basically, in the past, the medical students were going into residency, and they were telling them, we're sending you our good students, but now they're saying, please check them before sending them to us. So this was another big message that they were sending to the medical school. Again, these were factors posing challenges and areas needing activity. Basically, the same type of message. So one of the things that I thought was interesting, the survey is very long. One of the things that I thought was interesting in this survey was curricular models, because the current general surgery program is 5 years, and they were sort of toying with the idea of having this transition year before they go into unsupervised practice, or transition year before they go into subspecialty, some kind of transition year. The question becomes, this is 5 years, so how do we adjust this 5 years? Do we make it 4 years and add on a year here? Or do we keep this 5 years and then add on a year here, for example? So imagine if you're a resident and you're coming in. I mean, if you're a medical student, it's 4 years, but if you're told that you have to do another year, or if you have to do 2 more years of medical school. So anyway, there were several of these models that were proposed. The first one was a 5+1 model, so 5 years here, 1 year here, or 4+1, or 4+2, 4 years and 2 years, and then 3+2, which is 3 years here and 2 years here. You can notice that the majority of them they were pushing for an extra year to 6 years. This is 6 years, 6 years, 6 years. This is a 5 year. And when they asked the program directors, what is your one best recommendation? Although all of them were saying we need to do something about this, we need to change it, still keep the existing 5-year structure was 22%, and then this 5+1 was lower, and so forth. And this 4+2 was still slightly higher, but there was a lot of variability here. And one thing that we noticed was if you're a small residency program versus a large residency program, they had a lot of differences, because large residency programs might be able to add in a year, but maybe small programs, they might be different. So this was just one thing that I thought was quite interesting, and it was serious enough that they put it on a survey, and I think a third of the survey was dedicated to really asking a lot of questions about this. So one of the questions that they asked in the survey was, depending on these different types of programs, which do you think will make the resident more prepared for practice, which is more feasible, which is more acceptable? And you can see that the 6-year programs, the preparedness is much higher compared to this 5-year program. The preparedness is way down here, 26%. So the 4+2 model in terms of preparedness, I think is the highest. But then in terms of acceptability, or this is the highest because it's hard to change from a 5-year program to a 6-year program. So anyway, this is something that they've been discussing. I think they're continuing to discuss this, and so probably something might happen, or maybe not. But they're very seriously discussing altering the curricular structure. So just a few more slides. I'll conclude with some implications. So this was a framework that Tom Naska, he's the CEO and president of the accrediting body for graduate medical education. This is in charge of all of the residency and fellowship programs. And what he was envisioning was a very continuous, the x-axis here is resident year 1, 2, 3, and this is continuing physician. So he was envisioning this continuing medical education from when you come into residency from medical school all the way through, looking at different competencies. And this is a framework that a lot of the residency programs are now operating. And now they're adding in the medical school part, and so the figure is now like this. And that's the new figure that people are rolling out because they want to see a fluid continuum from medical school, residency, fellowship, practicing. And some people even extending it further to, because in the US you go to college and then medical school, so what should be done in college? And then what should be done in high school? And so these are some discussions that are happening in medical education departments. So why all of these different changes? I think in addition to the 100-year mark in the Flexner report, because that 100-year mark was a really fundamental mark in the history of medical education. But in addition to that, there's been a lot of movement by the National Institute of Health. So this is the largest funding agency for medicine and healthcare in the US. So all of our grant money comes from the NIH. And they're really promoting this idea of translational science where, how does what you're doing actually lead to improvement in patient outcomes? So in addition to this, the Institute of Medicine, this is where all of the biggest thinkers in medicine are coming together. They've released that report. It's one of the reports that I had earlier on in the slides. They were saying that there's a significant gap between the residents who are graduating and then the physicians who are practicing. And so we need to do something with this gap. And so these two giants in the funding area in North America were really vocal about driving change. And of course, because these two were driving change, the accrediting agency, the ACGME, released a lot of mandates. And of course, this now goes down to the undergraduate medical education and also the USMLE exams and so forth. And again, all of these are translating to different changes in residency programs, need for more valid assessments, and things. And then also at the undergraduate level, how students are preparing for licensure exam, how history is being taught and how physical examination is being taught, communication skills and so forth. And so I think a lot of, in some sense, earlier I was saying this is a very exciting time, but it's also a time where a lot of things are happening. And every few months there's a new announcement, it seems, that's happening. Because 7 years ago, they released the milestones, and then a few years later they released the EPAs, the Trustable Professional Activities. And then a few years later they released the OPAs. I don't know if you've heard of OPAs. And then now there's EPA OPAs. And these are new ideas that are coming out. And so there's a lot of new information that are coming out, and we're trying to understand what's going on. This is, I think, one of the last few slides that I have. I thought this was kind of interesting. So you can see that there's a lot of new mandates, new ideas that are happening with respect to medical schools. And there's a website called endstep2cs.com. It's a little bit small to see here. Step 2 CS is the clinical skills licensing exam in the US. So this is the exam where the student goes in and there's an OSCE. They go through 12 different stations. And this is a website developed by students in medical schools in Cambridge area in Boston. And they created this website, and they're going around the country, requesting for petitions. I think there are about 18,000 petitions signed now, and somehow this, I wasn't aware of this until there were people who wrote about that stop the Step 2 CS, because this is called Step Up, Not On, the Step 2 CS exam, and they're opposing ending the Step 2 CS. I just wanted to present you with all of the different things that are going on. And this is quite recent. This came out in August 2017, so less than 6 months ago. And then there's also another commentary that came out maybe around the same time. Can we increase the value and decrease the cost of clinical skills assessment? So these are, again, commentaries, reactions that are coming out because so much is happening to the community. So this is, I think, my last slide, just to recap everything that's happening. Medical education, the first 2 years, preclinical, and then the clinical, and then the residency. And there's a lot of concern about preparedness for transition, and then they're asking, each of the different components of the pieces, how are we doing to train the students to go to the next phase of training? Are what we're doing sufficient? Is it enough? And what can be done? And that's sort of the curricular trend that's happening in a lot of the American schools. So I think that's it. Well, thank you very much.
So thank you very much, Dr. Park. So are there any questions from